computer at home, but that should be okay.
And we are live, Senator.
All right.
I'll survive.
Good morning. It is Wednesday, April 26th. This is the Senate Health and Welfare Committee. And we are looking at a bill that's been returned to us from the House, S-37. And Jen and Amber, how do you want to do it? You both want to come up and walk through?
Yeah.
That would be great.
Carrie, I like your tie.
Thank you. That's a classic.
What is it?
It's like a
I'm sorry,
early
but
90s.
it's gonna make me smile all day long today when I look at it.
Remember that was their model? I think it came out of some Super Bowl
Totally.
commercial.
Is that right?
I love
Oh,
that.
that's cute.
I brought my checkbook today, by the way. Sorry,
Okay.
I know
Okay,
I should have said all this before we went live.
yeah, my kids gave that to me.
That's really nice.
We probably should put it up on the screen because not everyone has a piece of equipment with them. Oh, well, oh, good. So you've got it marked up.
Yes.
Excellent.
Cruising through it and scroll back at the beginning.
So this is the bill, this is the reproductive shield bill. And it protects providers, insurance companies and others from, as for legally protected healthcare activity. So why don't you show us what the House has done to the bill?
Certainly. For the record, Amber Nabajili, Legislative Council. And Jen Carvey, Legislative Council. What you're looking at right now is the as passed by Senate version of S-37 and Act relating to access to legally protected healthcare activity and regulation of healthcare providers. And then the markup is what the House is proposing be done to the bill as you send it over.
And our goal here is to decide if we will concur with the House or if we will add a further proposal of amendment, or if we will ask for a conference committee. So those are the choices that we have.
So starting first in section 1, you'll see the addition of the words including medications, so that the definition of gender affirming healthcare services would read means all supplies, care, and services of a medical, behavioral health, mental health, surgical, psychiatric, therapeutic, diagnostic, preventative, rehabilitative, or supportive nature, including medications relating to the treatment of gender dysphoria and gender incongruence.
This was a suggestion made in the House Healthcare Committee. There was a question, somebody asked a question about whether medication was included. And we thought it was sort of implicit, but this makes it explicit.
Okay. If anybody has questions, just ask them.
Sure.
It does seem redundant.
Okay.
Well, it's including it, so it's specifying.
Yeah.
That way there is no question about whether medication is or is not included.
Next, there's changes to the definition of legally protected healthcare activity. And I will, first, there's a technical correction. This is to match the punctuation between H89 and S37. It seems as if H89 had some editing where the editors changed these two to semicolons, but there remain commas in this bill. So we have changed them to make them match exactly.
Right. So as you may recall, the intent was for the definitions in H89 and S37 to match because they are codifying the same language to go in the same section of statute. And so it was important to us that they be
The same.
exactly the same. This is the kind of thing we could have fixed over the summer and summer statutory revision if necessary, but it seemed better to have the same exact provisions enacted since it's going in the same place.
Just a, again, a process question. So the House has a nearly identical bill to this.
So this is the House bill. This is what the House has sent to us. We sent the bill over.
Right.
House Healthcare went through the bill
Right.
and has made recommendations for change.
Right.
So we're looking at their changes
Right.
and we can decide.
Right. So what happens to the House bill? Is it just
H89.
Are you talking about H89?
Yeah,
Okay.
so that one is on the House calendar. House Judiciary, I believe, has looked at it and they're waiting to see what happens with this one to make sure that these definitions will stay the same, but it's only section 1 that is the same in both.
Okay.
Everything else in H89 is
So the
different and deals with the legal side, the judicial side of things.
So the definitions are important that they're the same because they're going into the same part, same statute. And I did talk with the chair of judiciary yesterday, and he's waiting for us to make our decision about how to move forward. And then theoretically, if we concur, we'd vote on this bill tomorrow, and the House would vote on H89 tomorrow, and they each go to the governor.
So I see a comma, a dash, and a semicolon.
That we're showing you the markup, so we would be striking the comma and inserting the semicolon.
Got it, thank you.
Yes, so that's not actually how it will appear in the bill, it would just have a
Yay.
semicolon. Yes. We had to go through it, manually mark it up. So then the big change in the definition section is one that you have actually already looked at as well in the context of H89. This is amending the definition of reproductive health care services. First to add that including medication language. And then says including medication, it said in medications and the beginning. I think it was medication and anyway. I'll have to look at that. So including medication, and then we have this subdivision 2 specifying that it includes medication that was FDA approved for termination of a pregnancy as of January 1st of this year, regardless of the medication's current FDA approval status, when the medication is, and then sort of all the stages of what might be done with it by a licensed provider in this state, a licensed individual in this state, as long as their actions conform to the essential standards of acceptable and prevailing practice for their profession, or when the medication is used by an individual. So this is, again, identical to that language we looked at in H89.
That was the amendment that Senator Hashim and I spoke to.
Exactly. Yes, it's just singular medication, so we're good.
Okay.
It's just an error in the markup.
Oh, at the very beginning.
At the very
wasn't it?
beginning.
Medications.
Yeah. you have
Oh,
medication.
what happened?
So I did.
Everything's okay?
Yes, everything's fine.
Everything's fine.
Okay.
No need to
All right.
panic.
We'd like to have reassurance from our legal counsel.
Yes.
Okay, all right, so we get that,
Yes,
We've seen
and as
that
you know,
before.
things are still in limbo,
right?
of course.
There
Limbo.
are.
Where's limbo?
In the courts.
Oh.
Yes, the situation is still in limbo.
With a prescription.
Yeah, yes, with that medication.
It's a small village in Sarah.
East of Wallingford, yeah.
Anything else?
Oh, yes.
Okay,
There are no proposed changes to section 2, which is the medical malpractice insurance section. And there are no proposed changes to section 3, 4, or 5, which is the insurance and Medicaid coverage of reproductive health care services, gender, and then the approval for the direction to the Agency of Human Services to seek federal approval if necessary to make these changes. And then the next set of proposed changes is in section 6. Section 6, if you recall, is professional regulation statutes related to those professions that are regulated by the Office of Professional Regulation. The first language here on page 9 is current statutory law, which I think probably should have gone, well, it's useful context for the following sections.
okay,
So
so
this is
they're adding current statute
Yes,
to provide context for the
yes.
following sections. Okay.
So this would read, in addition to any other provision of law, the following conduct by a licensee constitutes unprofessional conduct when that conduct is by an applicant or person who later becomes an applicant. It may constitute grounds for denial of a license or other disciplinary action. Any of the following items or any combination of items, whether the conduct at issue was committed within or outside the state, shall constitute unprofessional conduct. So that's current language. And now here within subdivision 7, which is current law, but has the addition here towards the end. Willfully making or filing false reports for records in the practice of the profession, willfully impeding or obstructing the proper making or filing of reports or records, willfully failing to file the proper reports or records, and then the new language, or willfully providing inaccurate health or medical information to a patient, including purposeful misrepresentation of a patient's health status.
That's a good, my opinion. Go ahead.
Who adjudicates whether something's inaccurate? Who's the board that would go to?
This is through the Office of Professional Regulation.
Okay.
Whether, it depends what type of profession, whether it's going to be the director or a professional board that's under the office is actually hearing the case.
Okay.
Could be a nurse.
It could be a nurse, it could be the nursing board.
Board of Osteopathy,
Right. Oh, true. Yeah.
Board of Pharmacy.
Okay, thank you.
Is there other questions on that piece? And then also adding another unprofessional practice standard, which would be a new subdivision 29, providing or claiming to provide services or medications that are purported to reverse the effects of a medication abortion.
That's the progesterone piece.
Yes.
Okay.
Subsection F is just the language you recognize from your Senate version, excuse me, as passed by Senate bill. Then we have some new language here to say that no healthcare provider who is certified, registered, or licensed in Vermont. We realize we typically have that phrase throughout the bill, so
Yeah.
we included it here as well as in the next section 7. Then subdivision B, and for context, we're talking about how the director or board shall not take adverse action on against a healthcare provider or against an applicant that's a qualified healthcare provider based solely on, and then first subdivision A is that provider providing or assisting in the provision of legally protected healthcare, or B, criminal, civil, or disciplinary action in another state against the healthcare provider. And that was in response to the Office of Professional Regulation asking for a bit of clarification about how we worded this. They're saying, could it be a civil action? Does it need to be civil action by a licensing board, or could it be a civil action by another entity? So for clarity, we just said a criminal, civil, or disciplinary action in another state, regardless of who is bringing that action.
It could be an individual too, right? And then it's the continuing language, so it's directly related to the protected healthcare activity.
Yes.
Okay.
For definitions for this section, the Board of Medical Practice and OPR both flagged in their testimony something that we did not catch on when this bill was in the Senate side, which is that the definition in 18 VSA 9496 specifically says, I'm paraphrasing, but a provider that's licensed or authorized to practice in this state. But we're talking about potentially people who are applicants to practice in this state. So we've removed that definition to not have an inconsistency between the definition and the provisions of this section. So the new definition here would be a healthcare provider means a person who provides professional healthcare services to an individual during that individual's medical care, treatment, or confinement. So it's mirroring in many ways the definition in 9496, but it removes the licensing and the authorized to practice language.
Right, it was confusing to use a definition that implied the person was already licensed when we're talking about somebody who might be applying,
Right.
might be licensed in another state and applying an applicant for a license here. To describe them, define them as somebody who's licensed here doesn't make sense.
Okay.
One of the other comments that was raised during testimony was whether whether professional healthcare services includes mental health care, and whether this also covers mental health professions. As you may know, usually when we talk about healthcare, we are talking about both physical and mental health. So we did not want to call out mental health care as if it's something separate from healthcare, as we do not do that anywhere else. So as a way to make it clear that we're talking about all types of healthcare, we added a definition of healthcare services, meaning services for the diagnosis, prevention, treatment, cure, or relief of a physical or mental health condition, including procedures, products, devices, and medications.
And both of these are definitions that are, or taken from definitions that are used elsewhere in our statutes. So we're not creating new definitions, but more spelling out the language.
Then section 7, you may recall, is a mirror of section 6, but now we're under the Board of Medical Practice Professions rather than OPR professions. We have the same language here about a healthcare provider who is certified, registered, or licensed in Vermont. We have the same clarification in subdivision B, so that it reads a little more explicitly: a criminal, civil, or disciplinary action in another state, and the same definitions that we just walked through.
It's the
It was there.
Fair.
Oh.
Fair. That's fair.
Okay, so this is a replication of what we saw earlier for the
Yes.
OPR, and this is for Board of Medical Practice.
Yes.
Okay.
The main difference is that OPR had those 2 additional unprofessional conduct standards,
Yes.
but otherwise the language is identical. Next is section 8, the pregnancy services consumer protection section. The committee opted to remove the word fraud really from the subchapter title. So it would now read pregnancy services centers. We reviewed the other subchapter titles within the consumer protection chapter and determined that this was more in line with how the other consumer protection subchapters are titled. They don't typically use the actual allegation within the subchapter title. They just use the entity.
Well,
Thank you.
it's a fresh air.
Yes.
Okay.
On page 13, and now we're in the findings section. The committee opted to remove one word from this sentence here at the top of page 13, so that it would read: accurate information about the services that a limited services pregnancy center performs, in addition to forthright acknowledgement of its limitations, is essential to enable individuals in the state to make informed decisions about their care.
That's good.
They thought having pregnant was not necessary.
Well, yeah.
In subdivision 2 on page 13, the last sentence, the committee opted to remove the word many and replace it with some, so that this subdivision would you like to read the whole subdivision for context? So the last sentence previously read: many limited services pregnancy centers have proven patently false or biased medical claims about abortion, pregnancy, contraception, or reproductive health care providers, and the committee preferred to say that some limited service pregnancy centers.
Do you know why? I'm just curious how this process works. Was it just?
There was a discussion about they heard from different witnesses to some extent than you did, and there was questions raised about whether there was enough data to show that many limited services pregnancy centers do this, or whether this is happening in Vermont or not. So a recognition that it may be, or they believe it could be happening, but to what degree is it happening? Is it many? Is it just some?
Okay.
They felt more comfortable with some.
Okay.
On the page 14, subdivision 4, the last sentence here previously read in the Senate version: without veracity and information and communication, it is difficult for individuals to make informed voluntary choices essential in fulfilling autonomy-based obligations. And the committee was uncertain what autonomy-based obligations were, and they asked that we rephrase that. So the sentence would read: without veracity and information and communication, it is difficult for individuals to make informed voluntary choices that are essential to one's sense of personal agency and autonomy. That's better.
Okay.
And I believe those are all of the changes to section 8. I was wrong. On page 17 in section 2493, this is the actual consumer protection language. The committee is proposing entirely new language for subsection B. So subsection B in the Senate version read, the medical director of a pregnancy services center or the individual charged with supervising healthcare services provided by center staff or volunteers of a pregnancy services center shall be responsible legally and professionally for the activities of staff and volunteers performing duties for and on behalf of the pregnancy services center. The medical director or individual shall ensure that the staff of the pregnancy services center, including the medical director or individual and any volunteers providing healthcare services, maintain a level of supervision, training, and practice consistent with legal requirements established under Vermont law. Failure to conduct or to ensure that healthcare services are conducted in accordance with state law and professional standards of practice may constitute unprofessional conduct under statute. So the new proposed language is healthcare providers licensed under Title 26 of the Vermont statutes annotated who are employed by, contracted to provide services for or on behalf of, or volunteer to provide services at a limited services pregnancy center shall be responsible for conducting and providing healthcare services, information, and counseling at the center. The failure of a healthcare professional licensed under Title 26 of the Vermont statutes annotated to conduct or to ensure that healthcare services, information, and counseling at the limited services pregnancy services center are conducted in accordance with state law and professional standards of practice may constitute unprofessional conduct under 3 VSA 129A and 26 VSA 1354. So the difference between these two language proposals, in the first section, we use the word medical director or individual who's responsible for overseeing healthcare services. And this language was recommended by the Office of Professional, the new language is recommended by the Office of Professional Regulation, because really their purview is over individuals who are licensed in Vermont. So if it's going to be unprofessional conduct, then it needs to be a professional that is already licensed here to provide healthcare services. So it's clarifying that they're not going to be trying to pursue unprofessional conduct for someone who is not a licensed healthcare professional. That being said, there are separate statutes that govern unauthorized practice of medicine. So the Board of Medical Practice or the Office of Professional Regulation could still pursue action against someone who's providing healthcare services who is not licensed or registered or certified to provide that type of care in the state.
Okay. Questions there?
The next change is section 9. This was originally in the as introduced version was 2 or maybe one-time report from the Green Mountain Care Board in consultation with, I think, the Department of Health at the time. And then the Senate version tasked the Agency of Human Services to include reproductive healthcare services and access to gender-affirming healthcare services as indicators for equitable access to healthcare in its community profiles of health and well-being analysis. And then also directed the Green Mountain Care Board to include reproductive healthcare service and gender-affirming healthcare service needs in the Health Resource Allocation Plan analysis, also called HRAP. So the House is proposing to first codify the requirement that the Green Mountain Care Board include reproductive healthcare services and gender-affirming healthcare services in their HRAP analysis. Previously, in the Senate version, it was session law, and the definitions were not tied. The terms reproductive healthcare services and gender-affirming healthcare services were not tied to any particular definition, such as the definitions that form the basis of a lot of this bill. So those were two of the aspects that we were looking at in this section and why some changes were being made. So this would amend section 94 5 of Title 18. This section is the State Health Improvement Plan and also the Health Resource Allocation Plan statutory provision. Subsection B is current law in statute. This is where it describes the Green Mountain Care Board's responsibilities for publishing on its website the Health Resource Allocation Plan, identifying Vermont's critical health needs, goods, services, and resources, which shall be used to inform the board's regulatory processes, cost containment, and statewide quality of care efforts, healthcare payment and delivery system reform initiatives, and any allocation of health resources within the state. The plan shall identify Vermont's residents' need for healthcare services, programs, and facilities, resources available, any additional resources that would be required to realistically meet those needs, and to make access to those services, programs, and facilities affordable for consumers, and the priorities for addressing those needs on a statewide basis.
Why is that relevant to this particular role? It's just sort of underlining that they have to articulate.
This is the existing language, it's just provided for context
It's
so that she
context.
can get to the, for when we get to the part.
Got you. That's context. That was.
Yes.
Yeah, okay.
Yes.
Thanks.
Now, this is why it's context.
Yes. So this section talks about what the board is required to do as part of the plan analysis. There is a subdivision 3, which says the board shall receive and consider public input on the plan. And then we're adding a new subdivision 4, which is where we're codifying this requirement. The board shall include reproductive healthcare services and gender affirming healthcare services as those terms are defined in 1 VSA section 150 in its plan analysis. So it's a lot of words to really just add that one provision, but context.
Okay, thank you.
Here. And then you may recall there was the language that came over from this committee around using the community profiles of health and well-being as another area where the state could look at data and gather data around where services are being provided and what the needs are. The House is proposing a new section 9A, Agency of Human Services, State Health Assessment, Community Profiles. The Agency of Human Services shall work with the LGBTQA+ community stakeholders and healthcare providers during the upcoming state health assessment and community profiles community engagement processes to explore barriers to equitable access to gender affirming healthcare services as defined in 1 VSA 150. And this proposed language was in response to some testimony from the Agency of Human Services about work that is already ongoing. What is the purpose of the community profiles? How does that process work? Is that a process that should have certain categories of care be required by statute, or should it be part of an ongoing interactive collaboration with those communities? And so the committee landed on language that just requires the Agency of Human Services to work with those community stakeholders and providers to explore the barriers to access. And there was also a determination by the House Healthcare Committee that reproductive healthcare services are already being addressed as part of the community profiles for health and wellness. And so they opted to just specify that this was for gender affirming healthcare services.
So that community engagement piece is also part of Act 167, so pretty timely.
The next section, section 10, this is the report back from OPR and the Board of Medical Practice on the state's compacts and whether there are any issues that need to be addressed by legislative action. The Board of Medical Practice requested that the date of this report be pushed out to November 1st, 2025 rather than 2024, as many of the compacts that the state is entering right now probably won't become effective until July 1st, 2024. So that would not give them much time to evaluate how it's going.
And this is, it includes the Board of Medical Practice, but this is supposed to be for all of compacts, correct?
Says OPR in consultation with the Board of Medical Practice.
Yeah.
OPR is the place, I think, where the compact person lives.
I
Lauren.
think it depends on the compacts, but a majority of the compacts involve OPR regulated professions.
Right.
I'm just wondering why specific, I mean, because there are a bunch of professions that have compacts, not just the Board of Medical Practice. So should there be consultation with the other relevant?
Read the first line after 2025.
I know, I see that it's
Okay.
Office of the OPR. I suppose the other boards are under OPR.
They're all
Is
under
the Board of
OPR.
Medical Practice is not,
Right.
so that's why, okay, all
Right.
right.
So they have the PAs and the podiatrists and the MDs.
And the psychologists and the,
But no, the OPR's got psychologists.
oh, right, yeah, I
Yeah.
meant OPR, okay, I get
I know, good.
Section 10A is the section where the state is directing the Vermont delegates as part of the compact to amend, if necessary, any compact language or rules or bylaws to include the types of protections, or to include protections for providers who are providing reproductive healthcare services or gender affirming healthcare services. There's one change in subsection A being proposed. That is so that the sentence beginning on line 8 will be read, therefore it is the General Assembly's intent to protect the ability of professionals licensed, certified, or registered in Vermont and professionals from other member states seeking to practice the profession in Vermont. This was in response to comments from the Office of Professional Regulation that under compacts, we don't really consider people from out of state being applicants because they're just exercising their privilege to practice. And then in subsection B, there was some testimony from the Office of Professional Regulation that, well, the language it became clear that the language could be clearer here as to the meaning in terms of the order of how we drafted this phrase. So the proposal is that this language would read, Vermont's representative or delegate for an interstate compact or agreement related to healthcare shall seek an amendment or exception to the language, rules, directives, or bylaws of the compact or agreement as necessary. And I thought that was clearer than to the compact or agreement language rules. And now I'm going to turn it over to Jen.
All right. So no changes in section 11 around pharmacists prescribing emergency contraception. In section 11A, this is the authority for pharmacies and post-secondary schools to have over-the-counter emergency contraception and other non-prescription drugs or articles to prevent pregnancy or conception available through a vending machine or similar device. And OPR noted during the process in House Healthcare that there seemed to be a conflict between a provision in elsewhere in Title 26 in this chapter that prohibits the Board of Pharmacy from making rules that otherwise relate to over-the-counter drugs. So this says, notwithstanding that piece that says Board of Pharmacy shall not make rules on over-the-counter drugs or devices, the board may adopt rules specifically related to the location, operation, utilization, and oversight of these vending machines. Then one small change in the this chapter in section 12 on the access to reproductive and gender affirming healthcare services reports. I guess a couple of changes. One of them is to take out, as you may recall, an earlier version when this was introduced related specifically to medication abortion readiness, and you expanded it to reproductive healthcare readiness. But we still had language that said reproductive healthcare services has the same meaning as in 1 VSA section 150 and includes medication abortion, and had the definition of medication abortion. Well, now that we have made it abundantly clear in section in 1 VSA section 150 that medication is included, and we even have specific reference to provisions around FDA approved and not approved, medications, that language was confusing to have in this piece. So that came out. But what I was really thinking of is in the information that the institutions will be reporting to the Agency of Human Services, one of the things that we had was in number 6 from this committee was the referral information that the institution provides regarding facilities that offer services that are not available on campus. And there was concern raised that referral suggested that was really from one provider to another provider, and what the idea was just what information the institution is providing about other facilities and not a specific provider referral. So they took out the word referral. No changes to the first report dates, and then a few changes here in this section 14 on prohibition on disclosure of protected health information. One is to add a definition of telehealth that is the same as we're using in other sections, because we're about to refer to telehealth down below. And then the changes, so these, if you recall, information in order to protect patients and providers engaging in legally protected healthcare activity, covered entities and business associates cannot disclose protected health information about that activity for use in a variety of proceedings unless the disclosure meets one or more of a list of conditions. And these two were recommended by the Board of Medical Practice. So in number 5, in addition to the disclosure being to Vermont's Board of Medical Practice, or OPR, in connection with a bona fide investigation in Vermont of a licensed, certified, or registered healthcare provider, this would add or a bona fide investigation of whether an individual who is not licensed, certified, or registered to practice a healthcare profession here engaged in unauthorized practice in the state, whether in person or through telehealth. So that's where the definition of telehealth gets pulled in. And the other that they requested was that the disclosure is to the Department of Health or Dale or both in connection with a bona fide investigation of a licensed healthcare facility in Vermont. Because between the Department of Health as the licensing authority for hospitals and ambulatory surgical centers and others, and Dale in its role doing survey and certification and licensure of long-term care facilities, they wanted this language as well. And then finally, we get to the effective dates and really just some conforming changes here, adding in section 9A, which is the community health profile section, right? And revising the title of section 10 to reflect what it currently says, reports and analyses. That is it.
What about the date of 2025? That's embedded in the language. Does that need to be here? No, okay.
Okay, no, that's not the report date.
Okay,
So that is
that's it. They made a lot of changes, but it looks like some, from my perspective, some improvements to the bill and adding clarity to the language. So committee, what we have before us is a decision to make. We'll come back to this at the end of the meeting today, but if there are any grave concerns about the language, let me know. We can find out at that point. You can tell me now. Otherwise, we'll go forward and concur with the House proposal of amendment to S37. Senator Hardy, go ahead.
Yeah, thank you. I'm just scrolling through to see, and I'm sorry, I missed the beginning, I was talking about cybersecurity in the hallway, but the amendment that we did on H89, that is also included in S37.
that's what's mirrored here. Yeah.
Okay, and the definitions all match up.
Yep, that's it. So yeah, that's the section 1. Section 1 is all the definitions, and we worked carefully
To ensure.
that they
And
are.
just, I
Okay.
think you weren't in the room, but
Yeah.
I had talked with the chair of the House Judiciary Committee yesterday. And what our goal is to make our decision on S37 today. H89 is up, ready to go there, and we'll both be acting on our respective bills tomorrow morning. So H89 in the House, or 1 o'clock tomorrow. We're both on the floor tomorrow.
Okay,
That'll work. Okay. All right,
thank you. Thank you both.
thank you both. So, and I'm looking for a little bit of a straw poll here. How are feeling okay with this? Raise your hand. Oh, and I know if you're not okay with it from the beginning, you may not be okay with it in the end, but that's okay. All right, but as a whole, we'll go forward with accepting the language from the house. Thank you. That's done. So we have H206 in front of us. And Ameren, we have a proposal, we have some amendments we want to put into the bill. Have we been through all those together or not? I don't think so. No,
There is some new
New
language.
language. You want to do that first and then we'll open up, folks. I know Rebecca Copans is here, Devin Green is here. Let's do that.
All right, so this draft amendment should be posted to your committee's page. This is draft number 3.1 regarding H206 and act relating to miscellaneous changes affecting the duties of the Department of Vermont Health Access.
Are we we're looking at the bill or we're looking at our amendment, so 3.1.
So the first proposal of amendment would be to change the report requirement in section 4 that's currently in H206. This is the report about federally qualified health centers and alternative payment methodology. So the proposed language here is the Department of Vermont Health Access shall collaborate with representatives of Vermont's federally qualified health centers, FQHCs, to develop a mutually agreeable alternative payment methodology for Medicaid payments to the FQHCs that is at least equal to the amount that would be paid under the prospective payment system established under the Benefits Improvement and Protections Act of 2000 on or before October 1st, 2023. The department shall provide a final report on the development of the methodology to the Joint Fiscal Committee, the House Committee on Healthcare, and the Senate Committee on Health and Welfare. You may recall in testimony last week on this section, you heard from a representative from Bi-State Primary Care concerning this section and proposing that there be alternate language, one that moves the date of the report, and also had requested sort of an initial report and then a final report. And then there was a request that stakeholders work together to come up with some mutually agreeable language. So
And Diva is in the room, so I'm seeing heads shaking yes. So this is great if we can get closure on that. It'd be good. We'll have you add in later.
So that is the first proposal of amendment. The second would be to strike out section 5, which is the effective date, and then insert new language. So a new section 5 here, and this section is different than the previous amendment we reviewed, but it's still concerning the same topic. So this is Blueprint for Health, Department of Vermont Health Access update on or before March 1st, 2024. I believe the previous date was either in December or January of 2024. The Blueprint for Health, in collaboration with other partners identified by the Blueprint for Health, shall verbally update the Senate Committee on Health and Welfare and the House Committee on Healthcare on a breakdown of Blueprint for Health per member per month payments to patient-centered medical homes and financial contributions for community health teams made by each payer for fiscal year 2023.
So I think my only concern about that is verbally, if we could say presentation, make a presentation, then we'll at least see something up on the screen or a PowerPoint of some kind. I don't know. Verbally, we might not, there's gonna be a lot of data here, a lot of numbers, and we don't wanna lose it, so.
Can you remind me, Madam Chair,
We're looking to see what
why
the
are we doing this? Why we want this?
this is something that I had added in and the administration and I have talked about, and it allows for an understanding of the reimbursement and the payments that are made based on both public and private insurance. So to look at how the Blueprint is funded per member per month payments, by public providers like Medicaid and private insurers.
But that doesn't, it doesn't say that in here. This is
No,
just payments to patients.
Yeah, no, I think that we can hear from the administration, but I think this is language that will cover what we would like to have covered.
It's just a report to the committee. It's fine with me. It's not clear to me why or what it is that we,
There's some concern about the relative payment to the Blueprint from private as compared with Medicaid, for example,
Mhm.
what the differential is,
yeah,
and whether or not Blueprint is paying for sufficiently by private insurers, and whether or not being paid sufficiently by Medicaid, so we want to get that. That's one area we're looking at.
okay. It just doesn't say that. So that was not clear to me that that's what we wanted, but
It did say it early. I mean, I had this long protracted thing, and then I asked the administration to come back with some recommendations. And they came back with a long story and a short story, and I picked short story.
Okay.
And so and I'm seeing,
All
do you want to comment, Commissioner?
I'm happy to comment.
Sure.
Sure. For the record, Andrea Delaware, Commissioner of the Department of Health Access. Good morning. So we've been on the periphery of this conversation. However, I think that the central office is comfortable with this. I think that they would come in and provide a verbal update and provide a PowerPoint anyway. I just think that is kind of customary.
Okay.
So if that satisfies the need, I think they're comfortable with this as far as
We might put the word presentation in there.
Sure,
Yeah.
whatever you think makes sense, but I think they would come prepared to do that anyway.
Thank you. All right, good. Okay. All right.
Section 6 is the same proposed amendment as in the last draft amendment, which is concerning the repeal of the repeal or the repeal of the sunset of the requirement for pharmacy benefit managers regarding 340B entities and 340B medications. That is unchanged from the last version. Section 7 is the language from S79 that we went through last week concerning hospital liens, with a small language change that I made in here, down in subdivision 3 at the bottom of page 3. So this subdivision would read: the patient's health insurance plan shall not deny payment for services furnished by the hospital to the patient on the basis that some or all of the patient's medical costs may be covered by a property and casualty insurance plan, unless such denial is required or expressly permitted by state or federal law. Previously, the language said something to the effect of shall not deny payment for services furnished to the hospital by the hospital to the patient on the basis that property and casualty insurance carrier is responsible for the patient's injuries. And that sounded a little not quite right. So
I'm sure you've heard from a few people about that one. Yeah, we didn't catch that one.
So I redrafted that subdivision and ran the language by some of the people you heard from last week to make sure they were comfortable with this language. So I'm sure you can hear from them about whether it's satisfactory.
That was nodding their head, yes.
That was the one change that I made to the hospital lien language from S79. And then lastly, the effective dates are new. The effective date section is new. The bill would take effect on July 1st, except that hospital lien section would take effect on January 1st, 2024.
Okay, so that's our proposal. Questions of Ameren? Okay, good. And we do have folks here who are interested in the proposal of amendment to the bill. We probably aren't. I'm going to suggest if you have a comment about the lien bill, maybe direct your comments to, yes, this is something we agreed to in judiciary, and then B, or two, that it's okay, you agree with the language that Ameren has fixed. Okay, I'm wondering, do you have a question?
I do, just on
Go ahead.
206 generically. So my understanding was at one point, this was moving towards appropriations. I was wondering, and I haven't looked into the detail of the big bill, this money for adult dental services.
It's in,
Okay.
yeah,
that's what I was-
the money for dental is in the bill, the increased amount to dental reimbursement and also the cap,
What cap are we at? We talked about 1,000, 1,500.
1,500, I believe it is. Okay, and that is in the big bill. So whether this bill will go, well, I'll talk with the chair of appropriations and whether or not she actually would like to have the bill go in or not. Good point. Thank you, Senator. So I'm looking at Diva. Would you like to make comments first on the sections related to you or to the bill, or are you?
I think we're comfortable, Madam Chair.
Okay,
I don't think.
all right.
Unless you.
Well, if you feel that you would like to, you're welcome.
Thank you.
Thank you.
Thanks for the opportunity.
Okay, so we have Rebecca Copans is here from Blue Cross and Blue Shield.
Thank you.
Okay,
Rebecca Copans, Blue Cross Blue Shield of Vermont. How are you? Thank you, Madam Chair, for having me and members of the committee. Blue Cross Vermont supports the provisions in H206. And I want to just speak to the proposed amendments, sections 5 and 6, and just say that we fully support the hospital lien section and the changes there. Section 5 talks about the blueprint report. And we feel that Vermonters' healthcare dollars are too valuable to not understand exactly who's benefiting from these programs and how these dollars are impacting health outcomes. And we request that you add to the reporting the actual number of patients served by each payer, by the blueprint program, and the services provided, not just attributed. There's an important correlation between this provision and the section in the budget talking about the blueprint that's asking for recommendations about how to increase funding for Vermonters with commercial health insurance. Any analysis of the program should evaluate not just who pays, but also who benefits from the services. This seems to be the question that's most often raised in legislative committees conversations around the blueprint, and having that clarity would help inform future policy conversations. We strongly believe that the blueprint should align with the state's health reform goals of increased data transparency, improved quality outcomes, for example, improved diabetic testing results, lower blood pressure readings, and higher colorectal cancer screening rates. And in order to show, that would show the value of the programs you're asking Vermonters to pay for in higher premiums. If you have any questions on that, I'm happy to answer them, or I can go to section 6.
so, and we don't have your comments on our webpage.
You don't.
So it'd be great to have those.
Yes, I will send them. I was writing it this morning.
I know.
So, apologies.
I know, end of session, we get it, yeah.
Any questions on the blueprint?
No.
So section 6, we do not oppose section 6. However, repealing it would provide more transparency into PBM payments by identifying 340B claims, which then can allow us to better understand drug costs and pass along these discounts to members through lower premiums. For an understanding of the broader impact to Vermonters from the PBM bill the legislature passed last year, Blue Cross Vermont members will pay $9 million more in QHP premiums due to an increase in prescription drugs purchased through hospital outpatient pharmacies in 2022. So this is a direct financial transfer from Vermonters that you serve to the hospitals with a 340B pharmacy. So when you consider the point that the Department of Financial Regulation made in their Act 131 report, that prescription medications have increased 35% since 2014 in the United States, this added burden to Vermonters is significant. When a brand drug is filled in a hospital 340B pharmacy, the consumer, either the patient or their health plan, pays the full price for the drug. The drug manufacturer refuses to pay rebates to the health insurer, which in our case are used to drive down member premiums. and lower costs for our self-insured customers because of the lower wholesale price for the drug paid by the 340B pharmacy. So they don't want to, they consider it double dipping. The hospital with the 340B pharmacy gets revenue from the spread between the lower wholesale price from the drug manufacturer and the full price paid by the patient or their health plan. Vermonters with commercial health insurance coverage do not benefit from 340B pharmacy discounts at pharmacies. FQHCs do offer a sliding scale, but there's no requirement for savings to be passed along by other 340B entities. If the goal is to positively impact the affordability of prescription drugs for those who are most on the hook to pay for them, 340B savings should be passed on to Vermont patients. Currently, the significant income derived from 340B programs drives up the cost for Vermonters who purchase health insurance. Premiums are based on the cost of care, so hospital costs and drug costs are the main drivers. So we would propose that the legislature increase drug price transparency, and hospitals should be required to report on their hospital budget filings, in their hospital budget filings to the Green Mountain Care Board, the amount of their 340B income they receive and how they spend it. Another piece to consider is just create a statutory cap on the spread that hospitals are allowed to charge Vermonters for pharmaceuticals. And we fully support the lien bill. So thank you.
No, thank you, and we'll get your testimony.
Yeah.
Everything you've said is really very helpful, and just so folks know, we do have a bill up on the wall. I think it's S98, which it talks about a prescription drug regulatory board or process, and all things that you've talked about are things that we might be able to look at when we come around to the next year, the biennium. So, yeah, so thank you for that.
Questions? Thank you for having me.
Questions? We didn't ask questions.
Oh,
We're
do
good.
you have questions?
We're good. Don't go away. Okay, Devin.
Thank you, Devin Green, Vermont Association of Hospitals and Health Systems. And I'm here just to talk about the Section 6, the 340B, making 340B protections permanent. So the 340B program came about in 1992, and it was a way to enable covered entities to stretch scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services. So this was funding for entities that were recognized as serving underserved populations. And so this goes to children's hospitals, critical access hospitals, disproportionate share hospitals, and those are hospitals that treat a lot of Medicaid patients essentially. Freestanding cancer hospitals, rural referral centers, and sole community hospitals. All of Vermont's hospitals, save for the Brattleboro Retreat, are eligible for the 340B program because they serve these populations. And previously, I would say that 340B was the hospital's margin. That's how crucial it is. Now that 9 of our hospitals are in red, it allows us to keep our doors open. So it's a very crucial subsidy for our members. In the past few years, there's been a concerted effort by drug manufacturers and PBMs to not go through the 340B program. So this protective language that we see here all came about because there was a PBM that was requiring pharmacies to do a report that pharmacies were not capable of doing. And if they didn't do it in 10 days, they would lose the entire contract with that PBM. So not just for the 340B medications, but for the whole book of business with that PBM. So it was extremely punitive. And that's why we put this protection in place. And that's why we ask you to eliminate the sunset here so those protections could remain permanent. One other thing, sorry. Oh, go ahead.
Just what's a PBM?
Oh, sorry. It is a pharmacy benefit manager.
Great.
And we can talk about
And that is a whole other day.
We can talk about what
I feel like this weird kind of scary deja vu happening with this conversation last session. Oh my gosh.
I will also say, I can go back and check, but I believe that we already report our 340B revenue to the Green Mountain Care Board as it is. I know that we've done that in the past, and I can check on that.
Well, maybe part of your budget process.
I think it's part of our budget
I don't know
process
if it's
already.
explicit in statute to require that.
Yeah, no, I think it's in the budget guidance, but I'll check.
Yeah, okay. And the pharmacy benefit manager, you'll notice the term pharmacy benefit manager. So it's an organization, something like Scripts.
Yeah, Express
Right.
Scripts.
Yeah, so it's an organization that negotiates with pharmaceutical companies to purchase drugs at a reduced price for an entity. So we have a PBM that purchases drugs at a reduced price for our Medicaid program. It is very helpful for that. If the PBM decides to be unhelpful, it could actually cause problems and increase the cost of drugs. It's really a black box as to how all of that happens. So when you look at drug pricing, the PBM falls into one of those places that suggest a lack of transparency in drug pricing. But if the benefit's good at the other side, then you don't want to throw the baby out with the bathwater. So it becomes a rock and hard place.
Thank you.
Simplify it completely, and we haven't talked about supplemental rebates or any of that stuff. We're not gonna. Okay, questions for Devin? Okay, good. So overall, I haven't heard anyone suggesting that we shouldn't go forward with the proposal amendment as it is, but there are other outstanding issues that we might want to address, in particular with prescription drugs. There's no question about it. So maybe we'll have a chance to look at S98 going forward. Does anyone else want to comment at this point? Who's here? Sure, David, please.
Sure, I don't even need, David Wickenberg here on behalf of the Vermont Association for Justice. We reviewed the language on the lien statute and agreed with everyone that it looks good and appreciate it, appreciate the catch, so.
Oh, good.
Thank
And
you.
Devin Green advised we're with the language as well.
Oh, good. Well, this is what we like to hear. There's a little comfort level going on here. This is good. Okay, anything else? All right. So it looks like draft 3.1 is something we can maybe vote on when we have our clerk back. So what we'll do is we'll move ahead. What time is it? Not what time is it? What time is on our agenda for?
We're well ahead of schedule, scheduled to start next week.
Yeah, good. Oh, yeah. Okay, so committee, let's take a little break. We'll come back. Let's come back at 10:20 and see if we can capture our clerk. And then we can have a discussion on 206, or what did I miss?
I just wanted to ask whether you would like me to change the language of verbally update to present to.
Please,
Okay, so
that would be good. And then we'll be ready to look at it. We'll come back at 10:20. At 10:30, no. Let's come back at 10:30. We have time. And we'll have a half hour to go through 206. We're back on our